And then if we could just start with some introductions. Renee, would you mind introducing yourself to the group?
Sure. Renee Bolio Banks, Indigenous Cause, Raganashimang, Zibiqua Indigenous Cause, Indigo, Zagasquat Jamaica, and Dunchipa, Nikizin and Dudain. My name is Renee Bolio Banks. That's my English name. My spirit name is River Woman. I'm from the Leech Lake Nation, and I'm the Eagle Clan. I've been at NACC for about a little over 5 years, and I'm the elder in residence. Miigwech.
And Dr. Robbie?
Yeah, hello, my name is Kari Rabi. I'm an addiction medicine and family practice physician. I've been here for 14 years now, I think. Glad to be here, thank you.
Nikki?
I'm Nikki Jardina. I'm a public health nurse at NACC, and I've been here off and on since 2017. Thanks.
And I'm Lindsay Kinkuni. I'm the Harm Reduction Program Supervisor. Been here about 2.5 years and happy to coordinate the Midwest Tribal Echo. All right, so I'm going to share my screen. We'll do some announcements. All right, and so welcome everybody to the Opioid Use Disorder Education and Treatment Series. We're the Midwest Tribal Echo. Today, I'm happy to welcome Ryan Kelly from Community University Healthcare Center, Shannon Clancy from Southside Harm Reduction Services, and Marissa Bonnie, who is on the harm reduction team here at NACC. They're going to be talking to us about improving access to healthcare for people who use drugs. Just a little bit about NACC. If you're not familiar, we are an FQHC. We were established in 2003, and we're located in the urban indigenous community on Franklin Avenue in South Minneapolis. This is a list of several of the services that we provide. We try to be a full spectrum harm reduction and medical clinic. We also have a dental clinic, IOP, building and behavioral health. Feel free if you want to learn more about us. We have our website down there at the bottom. This is a list of current open positions that we have at NACC. We are currently looking for a registered nurse for our outreach program, RN, a clinical support assistant, licensed dental assistant, peer recovery coach, advocacy and housing program manager, triage registered nurse, medical assistant, accounting specialist, and patient advocate. So again, there's our website at the bottom if you want to read more about those jobs that are open. Some session guidelines, please note protected health information. If you could keep yourself muted if you're not speaking. If you're willing and able to turn your camera on, we do love to see your faces. And then if you could just let me know who you are in the chat, and I can make sure to get information out to you after the session. And then we invite you to ask questions. Feel free to use the chat to do that, and we'll make sure to monitor that. This is a list of other echoes that we recommend that cover similar topics on opioid use disorder. Feel free to reach out to me if you want more information. And then we meet the first and third Wednesday of each month from noon to 1 p.m. Just an announcement on CMEs. We currently are no longer offering that service, but we are definitely trying to look into offering that again very soon. So I will keep you posted. And then next session will be a part 2 on syphilis with Alice Lehman, and that's going to be February 19th. And then finally for me, if you have case presentation examples to submit to us, feel free to email me. My email is right on the slide there. They make for a great discussion. So feel free to reach out. I think that's it, and I will stop sharing and I will hand it over to our speakers. Thank you.
Quick visual check. Can you see the PowerPoint, everybody? All right. Well, thank you, Lindsay. Happy to be here, everyone. My name's Ryan. I am a primary care and addiction medicine doc. I work at CUHCC Clinic, which is on Franklin and Bloomington, and also work at the University of Minnesota East Bank Hospital. And I prefer he, him pronouns, and I'll toss it to Marissa.
Hi, thank you for having me. My name is Marissa Bonnie, and I'm the Syndemic Program Manager here at the Native American Community Clinic. I also sit on the board for Southside Harm Reduction Services.
Hey, I'm Shannon. I use she or they pronouns. I am a program lead at Southside Harm Reduction.
So before we get into this, just a heads up, this was a talk that Marissa, Shannon, and I put together for fourth year medical students, and it was a 2-hour talk. And so we decided to keep all of the slides here, so any of you can, use them for, you just have the information at your fingertips. But a lot of this information will touch upon with the assumption that a lot of this you have heard in other echoes, and we want to make sure we save time for questions. And so getting into, we're all very well aware of, opioids and overdoses, and, the visual of when housing insecurity, the housing crisis, and fentanyl all kind of became a major issue here in Minnesota. We're very well aware that there are stark disparities in who overdoses. We've talked, on these echoes about structural racism, generational trauma, and we also know about fentanyl. I'm going to talk a little bit more about the fentanyl, though. Back when heroin was heroin, heroin is predictable. At its most potent, 100% heroin still was out of someone's system in 24 hours. If a higher up drug distributor adulterated the heroin to sell more, they were weakening it, watering it down. But then since, the early 20 teens, heroin has been mixed more and more with fentanyl. Now, there is no heroin, it's all fentanyl. But really what it is, it's analogs of fentanyl that are made in the lab, which means that the substances that are out there that people are using are much less predictable than they used to be. It kicks in very fast, very potent, makes overdoses easier. But even though the positive or euphoric effects wear off quickly, fentanyl and its analogs build up in people's bodies. And so true opioid withdrawal is very unpredictable and it can take a very long time. And it makes starting medications like buprenorphine products much more challenging. Going back to the consequences of using a drug that wears off quicker, people often will use more and have to use more frequently, which means bacteria from the outside of our body get inside, and hospital systems have been overwhelmed with complications of injection drug use. As more and more funds become available to try and help transition people to smoking, there's challenges with that too. But we're definitely able to answer questions about this later. And then I'm going to transition to harm reduction and have Shannon talk for a little while.
Hey, yeah, so harm reduction began in and is rooted in community care. Its frameworks really promote the human rights to just health, safety, and autonomy and agency among people who use drugs. In this work, also, we acknowledge that there are risks associated with drug use and sex work. And we understand that even though someone may not want to or be ready to stop using drugs, there are a lot of ways to support people by providing various tools, such as education and supplies and support systems to reduce the risks that exist. Yeah, you can go to the next slide. So there are many syringe service programs in the state of Minnesota, and they all offer a lot of the same things. The big ones being like syringe exchange and syringe disposal. So more broadly speaking, that's going to include like a variety of different types of syringe sizes so that people can choose what syringe size works best for them. And then what we call the works. So that's going to be waters, alcohol pads, cottons, cookers, and then fentanyl test strips, xylazine test strips, hygiene items. We also distribute naloxone and other supplies. Syringe exchanges also provide a lot of education. We hold a lot of conversations with people about safer drug use, how to respond to an overdose prevention, safer sex practices, and so much more. And then also rapid HIV and Hep C testing, having counselors available to chat with people about HIV and Hep C prevention and treatment is a big value of ours as well, and making that care accessible. And then also linkage to care, I think a lot of people don't know that syringe exchanges can be a lot of people's first point of contact when it comes to like receiving healthcare. And so we're here for that too, and supporting people and getting connected with providers that we're working with, and then also, really just working with what their goals are. Some other things that syringe exchange is do also include like secondary exchange programs. A lot of people, we see that like everyone that meets up with us is also making sure that people in their community are accessing the supplies that they need. And so we really like to honor that. And so some programs will also offer incentives for people to do that as well, because that's a lot of work. Yeah. And then just some things I think, like when we think about harm reduction in clinical spaces, I think some things that we can really focus on is using stigma-free and trauma-informed care in your practice. So like, especially within like the language that we use with people, especially in medical charting, practicing reflection is really important as well. Reflecting on your bias and privilege around drug use and sex work is very, very important. And I think also like really setting people up for success, like, are we setting goals that align with the goals of the person that we're working with, or are we setting goals based on like what we think someone's goals should be? Yeah. Ryan, do you have anything you want to add to this one?
Yeah, I think, and we'll talk later about goal setting. I think providers, especially, we often, if we see someone in the hospital with a complication of substance use, if we walk in with the assumption that, oh, your goal is to stop doing this and I'm going to help you, we're missing the patient side of what is their goal at the moment and how can we wisdom share whatever their goal is, how they can achieve it. But then your last point there, the referrals network and establishing relationships with trusted providers, we'll talk a little bit about that too. I think you mentioned that certain service programs are sometimes the first health experience that patients have had that was positive. And so how can we kind of use that relationship to encourage other relationships with other areas of healthcare? And so, before we talk more about, addressing disparities, improving health, I think trying to understand the challenges people face seeking healthcare in general is really important. I speak for myself. It's very late on beyond my training. I was already out of training and practicing when it really had, folks had, helped open my eyes to the challenges that people seeking healthcare face. The way our health system is set up, many people don't have the luxury to focus on their health. If you think about what you need to do to make an appointment, like I had a dentist appointment this morning. If I didn't have a phone with a calendar and a reminder, there's no way I would have made that appointment. If I didn't have Google Maps remind me where the dentist appointment is, because I'm terrible at directions, I would have made it. I need transportation. If I didn't have a safe place to sleep last night, making it to my dentist appointment or to healthcare would not have likely been the number one priority. If I was outside and looked like I had been outside and didn't have access to hygiene, and let's say I make it to a medical appointment or, where I'm a little bit late and I'm cold and I'm uncomfortable, and then there's a security person there looking at me, wondering what I'm doing there, that just adds to the continued medical trauma people go through. But let's say someone does brave all of that, and they do get in front of a provider. The provider orders medications. Well, unless the pharmacy is on site, you have to have the script sent properly. You need to have transportation, you need to have insurance, you need to have identification. So point being, there's a lot of barriers that many of us don't think of. And then when people aren't able to focus on their health, things get delayed. And so when it comes to people using drugs, if someone is injecting and they have wounds, or if they're feeling unwell, they have fevers, if going to the emergency department means being in a waiting room for an unpredictable amount of time, and you don't know when you'll be seen, and you don't know exactly when you'll be going into withdrawal, and then you don't know if you are seen, if you'll be treated treated the way we would want a relative treated. And then let's say you do get admitted, and you need weeks of IV antibiotics, but you don't have a home to go to do the IV antibiotics at home, so you're forced to stay in the hospital. And then the hospital doesn't have, cultural support, cultural appreciation. They don't have a wisdom sharing process of identifying goals. This leads to undertreatment of pain, for example. And then let's say, if I, was going to go to the hospital and I was worried that I would be in the waiting room for a long time and may go into withdrawal, well, maybe I'd have my own supply. And then I get admitted to the hospital, and the way I've been treated before, I don't trust appropriately so the healthcare team. But the healthcare team may not know how to break down those barriers and discuss what self-medicating in the hospital, what the biggest risks are, right? If you are using by yourself in a room and you overdose, no one's there to rescue you. You can worsen medical complications, etc. But if this isn't addressed appropriately, it leads to ongoing stigma. This can lead to people leaving the hospital early and worse outcomes. And so I think trying to have a system in which no matter where someone is seeking care, if there's a harm reduction lens that's focused on wisdom sharing and developing relationships and identifying goals, we will help people heal. And so I'll transition over to Marissa to talk a little bit more about understanding the patient's perspective.
Thank you. Yeah, so I think that like first and foremost, it's so important to first of all understand, are we having conversations with people about drug use and sex without stigma and shame? Drug use and sex are human decisions, and if we continue the systems in which people face harm by stigmatizing people around this, it's going to continue that. And so I won't go over every question in this slide, but how are we engaging with patients and participants about their drug use? Are we offering resources? Are we making sure that they feel safe? Are we making sure that if they are using, do they have wounds or sites they're worried about? And around sex, it's like, do we know what consent is? Do you have access to resource? Do you know about certain STIs or infectious disease? Are you safe with your partners? Things like this. And I really want to say it's like such an honor to be able to have these conversations with people and to be able to really absorb what is being told to us. And I really want to highlight when we are having these conversations, if you don't know what someone's talking about, or you're unfamiliar with a substance or some type of sex people are having, or like, someone's engaging in sex work and you're not comfortable or familiar, it's okay to say that. People can really pick up on when you don't know, and do again, the honor of being like, I'm not familiar with this. Do you have the capacity to talk more about this or teach me, or can I connect you with someone who would know better? And I think really practicing our humility around that is really what harm reduction is about. It's not being someone who has the answers, but we're always learning and things are changing. So I really do want to emphasize that the first step is really, how are we talking about these things that we as humans do without punishment or cruelty? And then we can go to the next slide. So kind of what I already said and what's been mentioned, why are these conversations important? Every opportunity to talk openly with somebody about safer drug use and sex is a way to open up conversations of care. I know in my own experience, just chatting with folks about drug use, whether I can relate to that from my lived experience or not, it really opens up pathways of linking people to community organizations within the clinic and within community care. It's really beautiful. Many people are criminalized, judged, harmed, or shamed for sharing honestly about their experiences to survive. And it's our role and responsibility to support people as best we can, to hold space and respect to participants' knowledge and their lives. It's not common for people to do this in care settings due to the situations named above. Also, when people are faced with incarceration, forced treatment, or other limited outcomes from drug use, the ability to share honestly can feel really impossible. So again, creating a safe space to hold these conversations is really important. Also, a lot of education around drug use and safer sex can be verbal. With the lack of phones, computers, our interactions are incredibly important to provide this information, especially when there is a lot of misinformation or stigma around drug use and sex in society. We want to make sure that we're really giving people the best knowledge that we can and share that. And then, again, the world of drugs are constantly changing. So with meaningful conversations, we can share the updated information that we have the privilege to have access to. For people who are directly affected. And so I know, again, this is a lot of words, so I won't go through due to time, but I really want to highlight something that Shannon had said earlier, which is, we want to hold a space that's safer and not a savior. We're here to support people where they're at, and we're not here to save people in response to their use. And really creating healthcare plans with the patient that is manageable or attainable for them can be can create a lot of success for that person instead of what we want for them. And especially with the luxuries that people might not have access to, that some might, really working with people around, how can you get to your appointment? What feels the most important to you in this moment? Can we help you with transportation? Do you want to talk about, your mental health, or can I get you harm reduction supplies? It's just all, it can be a lot, and it's overwhelming even in my own healthcare. And so I think it's really, really important to really focus on what the individual wants and not what we want for people in their health. Yeah. And then how stigma and bias negatively affect people who use drugs. So this is just, there's a lot of stigma around drug use and sex work. We often hear from our participants how stigma affects people when they're seeking care or going about their daily life. People really confide in us about their experiences with stigmatized care through medical resources. Example, going to the hospital or the ER, trying to get prescriptions filled, trying to access syringes at a pharmacy, accessing supplies for HRT. And then when there is stigma around these things, it can shame or create trauma for folks to not want to go back into their care. So really working on eliminating stigma, bias, racism, classism, transphobia, homophobia, sexism within our organizations, communication, and service delivery can significantly impact how someone chooses to receive and seek out care. And some things that we see that has been really successful is having accessibility of services. Doing pop-up mobile care is something that's in this photo here, but it's something that, we bring care to community, whether that's harm reduction supplies, rapid testing, MAT, vaccine, food resources, things like that. Getting the invitation from people saying, hey, is it okay if we come here and share our resources with you? It can really impact people's care and getting people into brick and mortar sites instead of expecting people to just come in. Also providing people with culturally specific care. That's so valuable. If people can connect to culture through language, medicine, just being able to be within that space is so powerful and valuable to people. And if it's something that you can't provide within your own services, it's really important to talk to community partnerships that are trusted, that you can refer to, and be able to build that bridge if people are seeking that. And then providing low barrier accessible services. What does it look like when you enter your clinical space or your drop-in center, or what does it look like to make an appointment? And is harm reduction practiced throughout the whole building? Yeah. And then I'm just gonna, sorry, that was a lot. I'm gonna hand this over to Shannon next. Thank you.
Yeah, and then I think too, like, you know, having conversations around safer drug use helps lessen the risk of adverse outcomes. And it also helps people feel connected, supported, and informed about their choices and their options that they have. I think just to highlight too is just that like any drug can be used safely as long as you have the right resources and support. We can go to the next slide. Yeah. Asking people, you know, if they have supplies or access to supplies, are they connected with an SSP? What are any limitations in accessing an SSP and how can we support them in that? Safety planning, I really like to use the risk set and setting model. Are you returning to use after a break? That's a risk. You know, how can we like create an environment that is safe and that you're watched over, and someone's checking on you. So who is around? And then also like, how are you feeling? Are you trying to get well? That really impacts the headspace someone might be going into their use with. And all of that's really helpful just to bring awareness around when talking with people who are using drugs. And then basic safety tips go a long way too, reminding people to start low and go slow. You know, that there are many different forms of administration that people can try out to give different parts of their body a break. Starting with the test shot, rotating injection sites, testing your supply, using drug testing services or using test strips, staggering your use while in a group so that someone's always present and able to respond if something were to happen. And listening to your body, drinking water, having a snack. Yeah, all of those are real important. And there are lots of different ways someone might choose to administer drugs. And I won't go over like all of the different ways, but each thing has its own, you know, reason behind it. I think that the route of administration someone prefers can be impacted by so many factors, including like finances, access to safe supplies, or even time. Like if someone needs to get well, how much time do they have to do that? So yeah, these slides are there in case if anyone wants to like check those out, to kind of see what different types of administration methods there are.
And so again, you know, emphasizing, you know, from the provider side, why this matters. You know, if I, you know, am one-on-one with a patient, and if I'm able to have learned from a previous patient about how to wisdom share with someone new, or if I'm in front, you know, talking to a patient and they're talking about something I'm not familiar with, having the confidence and having the confidence, like we already said, to ask, hey, can you tell me more about that so I can learn from you? It really allows us to address goal setting from the person's perspective, not from my perspective, right? And if we can discuss whatever someone's goals is, if they're still using, and I can discuss how they're using, and we can actually wisdom share ways to use in a safer way, that's building rapport, that's building trust, and that's helping people be safer. We're going to skip through this, some of the local and legal supports for harm reduction over the past few years. This is ongoing. We love to talk about safe recovery sites, safe use sites. If you guys have questions at the end, and then I'll transition to Marissa, who'll talk a little bit about the future, and we're getting close to the end.
Thank you. Yeah, so just to touch base on some things that are current or the future, or maybe paused in this time. So overdose prevention sites, those exist, they're real, and we put a link on this slide here so people can access this later, but there's a lot of really great information from On Point in New York City, but it's a place where people can access safe use supplies and use on site. And they have people there who can reverse overdoses if somebody does experience that. And it's also a place where people, again, can seek further care, not just using supplies. There's just like so much resource in that space, and it's really a beautiful thing. And as far as something we wanted to bring here is if people had access to safe supply, which essentially is prescribed substances, people would be less likely to overdose. And there is actually a really amazing data and just research around that through DOLF. And we put the link in here too for it's the Drug Users Liberation Front outside of Canada in Vancouver. And they executed their own safe supply program. And then also worked with some prescribers. So if people are interested in how that worked, there is information for that. And then drug checking. Drug checking is something that is becoming a little more accessible to us in syringe service programs and harm reduction programs. And it's great because those machines have worked in settings more around hospital or police enforcement, but we are having access to be able to connect drug checking resources with drug users so they can understand their supply and know what's in people's in their supply. And it's a pretty amazing thing. And obviously the future will always be to continue to work towards undoing the drug war through decrim and unlearning, and to really emphasize that drugs are not inherently bad. And we do want to name, we always want to have more resources for pop-ups and mobile care and low barrier care. Yeah, and I also want to name too, like there are overdose prevention sites within drug users communities. It's not just like named as a site that is like by New York or whatever, but we just want to name. A lot of this comes from drug users' experience and knowledge, which is incredible.
And then talking a little bit more about the future and hopefully the very near future, I think if, how can we improve the transition from one place of seeking healthcare to another, improve the rapport and the connections. And so, for example, if Shannon is, working with Southside and has someone that she meets who has been mistreated seeking healthcare, but she knows Marissa and knows Marissa is at NACC that day and is able to, educate someone to, hey, go to NACC and ask about Marissa. Then that person maybe have a little bit more confidence going and talking to Marissa. If Shannon is seeing someone who is febrile and really should be going to the hospital, but is nervous, well, Shannon knows me. Shannon can call me. I work in that hospital. If one of the ways that will help support people is if Shannon or a peer support specialist or someone else goes with that person to the emergency department to help with moral support. Once they're checked in, I'm able to provide a phone call to the emergency department medical provider to give a little backstory to say, hey, this person's scared to death of seeking healthcare because of the way they've been treated in the past. They're also really worried about going into withdrawal in the waiting room. If you see them, we know they have opioid dependence. If you can provide them with opioids to allow us to do our medical assessments, and if they get them into the hospital, our harm reduction team will build goals with them and take care of that responsibility from you. That helps the medical provider in the ER not feel like they have to come up with solutions for everything. They can say, all right, this person has been triaged. I can get this person taken care of, get the ball rolling for going into the hospital or assessing do they need to go home. And I've got this other care team that will help with some of the things I'm not as comfortable asking someone about. From the patient side, we have seen it definitely helps the confidence of going to the hospital and helps people sometimes stay in the hospital a little bit longer. And then finally here, I want to mention a medicine called Brixadi. And again, if people have questions at the end here, we're definitely open to answer that. We mentioned very, very early on the challenges going from fentanyl to buprenorphine. That the properties of fentanyl and analogs of fentanyl means it's very difficult to get started on a medicine like Suboxone. However, Brixadi is an injection that is a very slow onset version of buprenorphine, and people are able to get that shot when they're in early withdrawal. And so if they are interested in being off fentanyl for a while and wish they could get on Suboxone but can't, people are able to get a shot of Brixadi after 12 to 24 hours of no use. And it kicks in slowly. So they slowly start feeling better without withdrawal. And then by the end of the week, it's kicked in fully, and they can then decide, am I feeling okay like this? Am I not ready to do this yet? And I go back to use, or am I interested in switching directly to Suboxone, or even getting Sublocade, which is a month-long injection of buprenorphine. At the moment, the only way people can access this medication right now is through the Fairview Riverside Emergency Department on West Bank, because they have a grant, but we're hoping this will be available, in other ways in the near future. And then I think we've got several areas of, Shannon, is there anything you want to add about the literature that we have here and our other resources?
Yeah, sure. Our website, southsideharmreduction.org, we have a little library. Feel free to check it out, especially as providers. I think a lot what's listed on there is really great handouts for people that we're working with. And then here's also just kind of a long list of books that we really love and have like talked about in our little nerd circles and wanted to share with people. Yeah. Oh, and then also for Minnesota, the updated monthly SSP calendar is also on our website, and that's updated monthly at the beginning of each month. So if you're in Minnesota and you are looking for that, you can always go to our website to get that update. Yeah.
And so I think that's the extent of our talk. I can stop sharing my screen here in a moment and see what questions there are. I see there's already one on Brixadi, but maybe I'll stop sharing just so we can see each other. So like I said, we talked a little about a lot of things, but are happy to answer questions. And Julie asked a question about, Julie, you say your patients are loving Brixadi, and you're wondering about patients getting it. Is that right? Julie, are you still on? Just in case Julie's not able to talk. So, I at my clinic and on East Bank, we do not have access to Brixadi yet. My understanding, the state has not figured out the prior auth process for Brixadi officially, and so it's currently available via grants. And so the Fairview Riverside Emergency Department has access to it right now, and that works. Anyone showing up to the Fairview Riverside ED saying, "Hey, I feel unwell. I use opioids. I want to get the shot of Brixadi," they'll get a shot, and then they'll get linked to whatever support they need within the next week for follow-up. Dr. Robbie, do you have anything to add?
Yeah, just that. Well, I'm nervous to say it because we're just starting, but we will be having Brixadi as well coming up. So very curious to hear, like what patients' experiences are, and just how to integrate it into the whole spectrum of the things that we offer. But I think we'll have it like next week or something.
I have an unrelated question, if that's okay. I just wanted so you guys did talk about this in terms of like taking a harm reduction approach to documentation, to like clinical documentation. And I guess I feel, yeah, like this is on my mind a lot, the sort of double-edged sword of the EMR, and particularly of like a shared EMR and of care everywhere. And we come up against this in a lot of complex situations where, like, maybe we want to add a certain diagnosis to somebody's chart or put something in a note in order to communicate something that will ultimately help with continuity of care if the person is seen by another facility or another provider. But you know, we also are just like aware of the realities of the fact that like some external providers may, or institutions may see those things and interpret them in a judgmental or stigmatizing way or discriminatory way. And, you know, so it's tricky to know, like, do we want to make, you know, certain notes private, but then if that note contains sort of pertinent clinical information, it then like limits that care. It's all, I mean, so I don't, you know, I'm not necessarily asking for like the perfect solution, but it's just been a lot on our minds, especially because we at NACC switched from centricity to Epic about 7 months ago. And so we no longer have our nice little private EMR where we can just sort of, you know, and that's been a really different experience too. But it can feel sometimes like you're writing a note that's so vague.
Yeah.
That are you really communicating something that is pertinent anyway? So.
We try to practice advocacy in our notes, you know, as we, you know, as we're writing them.
You know, it's, you know, we have a person who just had, you know, a major, you know, for years had a congenital organ problem, you know, a heart problem that was congenital. At one point in their life when they're younger, did use drugs, and you know, the notes from the cardiologist all talk about meth-induced cardiomyopathy, and it had nothing to do with that. Like, it was like, no, in your note from before, it's congenital heart problem, and it just kind of carries. And so you're exactly right, and it definitely negative impacts. I also don't have a solution. It's tough because, you know, we do have that extra layer of protection when we're talking about addiction. If we have that dot phrase, the federal whatever statement that is.
Yeah, we use that for MAT.
Yeah.
But we didn't start out there, you know, we sort of circled back to there.
Right. And so like someone would have to break the glass to read those notes. But, you know, because on the one hand, it's important if I'm having someone, if someone has hepatitis C, right, and they need to see a specialist for whatever reason, you know, ideally the specialist that they're seeing would have a harm reduction, trauma-informed way of talking to someone about their risks. Unfortunately, we can't control the negative behaviors that our colleagues elsewhere perform. So it is hard. I don't know if anyone else has thoughts or experiences on the documentation side.
I've found it to be really helpful too, to like, you know, with diagnoses, like talking about that with the people that you're making the diagnosis with, because then, you know, if it does come up with another provider, they're able to like advocate, you know, for themselves and like their side of like, hey, like we were a little bit unsure about this, like we're not sure if OCD is something that I have, but we're keeping an eye on it, and like able to like really advocate for themselves and communicate their side of it too. I found that to be helpful, but that's more mental health than the medical side too. Yeah.
If I'm driving, Claire, go ahead.
Here, let's see if you can see my face. Oh, I'm Claire. I am the Hep C epidemiologist for the state of North Dakota. We do get a lot of patients from the western side of Minnesota and do similar work. Well, I mean, not even up to near par, but trying to do better work. But talking about like EMRs and harm reduction, or you know, we just started tracking perinatal Hep C cases, and we are running into you know, like how do you go about at your clinic just like harm reductive prenatal care? So in our state, Indigenous women are the most affected by hepatitis C and syphilis, and we're just they're so scared to come to care because they're going to be, you know, demonized. They want their kids taken away, and we're trying to figure out how to better educate providers so that we can actually treat Hep C and syphilis in the state. Anything about that? If that is a question, does that make sense?
I mean, yeah, so Minnesota's lucky in that we had some great advocates change mandatory reporting. I'm curious if anyone here is who wants to speak on that, because I think we had an echo about that, right, Dr. Robbie?
Yeah, so the Minnesota the mandated reporting laws did change, and if a pregnant woman is engaged, a pregnant person is engaged in care, then we no longer need to report. However, like we are having conversations at our clinic around what that means in terms of advocacy and in terms of preparing women for, like if you don't report during pregnancy and then they at the delivery, there still will be social workers called and potentially CPS involvement. And then as far as charting and that goes, we try and practice advocacy in our notes, but our prenatal notes are open because that is important for the, like the OBs need to know and the pediatricians need to know. And we definitely come up against hepatitis C babies are not, the babies who have been exposed, the babies who've been exposed to hepatitis C in utero are not well tracked or monitored or followed. So we sometimes, our pediatrician will sometimes test regardless. Was that the question? I'm sorry. There's like there's a large body of information there potentially.
Well, and I think also, I mean, so Dr. Robbie has been providing perinatal care to people who are using substances and unhoused in what we think is a harm reduction model. And so I think that like there could definitely be an opportunity for like a more one-on-one conversation about that.
I'd be happy to connect.
Yeah. So.
Definitely. I was more interested, since you said you were talked to fourth year medical students, like how in the state are you disseminating like that info about like mandating reporting, or like, how different practices are changing? Because we're just really slow to get providers to be on board with that, which makes sense because we're North Dakota.
Let me send a quick message to someone who just joined to see if I can throw them under the bus.
I feel like it's disseminating slowly here as well, and I feel like there's such a variable feelings of personal competence. Like different providers have different levels of comfort with sort of managing that and handling that. And in some ways, I think for a lot of providers, CPS felt like a safety net. It's like something to hand something off to when they didn't know what to do. Yeah. But sorry, who were you going to throw under the bus, Ryan?
Well, I thought I saw Nate. I was wondering if he knew about any big movement state level wise that's been going on to educate folks. But I know the Minnesota Medical Association helps give information, but that's a very small subset of medical providers. I think as far as mandatory reporting within OBGYN, I know there's been a lot of the advocacy has come from obstetrics, but I'm not sure what the actual reminders to people that no, you don't need to report that. I'm not sure. And I also am not sure on the CPS and ICWA side where they're at. I'm not sure.
Nope, that was so helpful. We have some similar in the state. Our mandated reporting is a little bit different and and is decreasing too, so that's good. But yeah.
Any questions in the chat?
Does anybody have any other questions for the group? I have, let's see. I think Nate did comment in the chat, Ryan.
Perfect. Yep, I see that.
So he said, sorry, not in a spot to come off mute. There hasn't been any formal programs from DHS. I know this concern and issue is on the radar of colleagues at DCYF. All right, well, I think we're almost to time if no one has any other questions or comments. Sorry, can, oh no, that's okay. If we can end it. Thank you so much. Let's see, there might be one other. Oh, Marissa said, please feel free to reach out if anyone has any questions. Yeah, thank you all. Thank you, Marissa, Shannon, and Ryan for joining us today. I'll make sure to get, it's okay to share slides, right? Great, okay. I'll make sure to get the slides out to everybody, and yeah, feel free to reach out if you have any other questions or comments for us on today's session. Thank you so much, everyone, for joining us. We will see you next time, hopefully. Our next session is in 2 weeks on Wednesday, February 19th at noon. Hope everyone has a good day. Thank you.